Dr. Uma, shall we start?
Yes. I'm ready. What about the other judges?
Yourself, myself, and Dr. Rashmi. Dr. Rashmi, I don't think.
Sure, we can start, sir. Norman, sir, good afternoon. I didn't see.
Good afternoon. Good afternoon.
You will start, sir. Sure, sir.
Yeah, I think the first paper is Syed. Are you there, Syed?
Saida, yes.
Saida, I'm sorry. Okay. You can start. You can start.
Good afternoon, everyone. Today I'm presenting a paper on study of dry eye and psoriasis patient in a tertiary care hospitals. So my chief author is Dr. Kavita M. Selgar. First is introduction. Psoriasis is a common chronic disfiguring inflammatory condition of the skin with several extracutaneous manifestations. Psoriasis affects 1% to 3% of adult population with various extracutaneous manifestations such as joint involvement, eye involvement, and an increased risk of coronary artery disease. So around 10% of psoriasis patients have ocular manifestations. Ocular manifestations of psoriasis are numerous and affect almost all parts of eye, and these effects can cause loss of vision. The various manifestations may be due to the disease or as a result of the treatment given for the disease. In psoriasis, several ocular manifestations have been reported, which includes dry eyes, blepharitis, both anterior and posterior blepharitis, conjunctivitis, keratitis, uveitis, cataract, and glaucoma. Patient with psoriasis present with complaints of grittiness, burning, feeling of dryness, redness, crusting of lids, they were examined, and ocular manifestations of psoriasis may be missed in the absence of thorough ocular examination. Material and method. Our prospective observational study includes 50 patients with psoriasis. Complete ophthalmological examination and test for dry eye like tear film breakup time, Schirmer 1 and Schirmer 2 were performed in all subjects, and distribution of patient with various dry eye tests were noted. We include the patient with all diagnosed psoriasis patient and with either sex and all age groups. We exclude the patient with other serious comorbid conditions, patient on poor therapy, and patient with other systemic illness like diabetes mellitus, hypertension, bronchial asthma, which may have similar ocular findings, and immunocompromised patients. So our results shows distribution of patient with ocular manifestations in psoriasis. So first is the dry eye. It is more common in psoriasis patient, which is 25 out of 50 patients, and blepharitis is the second most common, that is 17 patients out of 50 patients, and other ocular manifestations are seen in 8 patients out of 50 patients. Next is the distribution of patient with various dry eye tests. Here, study was shown that tear film breakup time, Schirmer 1 and Schirmer 2 showed statistically significant positive result in the psoriasis patients. First is the Schirmer 1 that shows like 10 patients shows less than 10 mm of wetting, and 40 patients shows more than 10 mm of wetting. And in Schirmer 2, in this 15 patients shows less than 5 mm of wetting, and 35 patients shows more than 5 mm of wetting. And tear film breakup time, here more than 10 seconds there is appearance of dry spot in 30 patients, and less than 10 seconds appearance of blood dry spots in 20 patients. So here is the one patient we have did the dry eye test, the Schirmer test. Next discussion. Study noted our study noted distribution of psoriasis patient with ocular manifestation out of 50, that is 50% have had dry eye, 17 patients have blepharitis, and 8 patients, 16% patients had other ocular manifestations. These observations shows that dry eye is more common in psoriasis patients than blepharitis, and other ocular manifestations are less common. In Schirmer once measured the reflex and basal tear secretion. It was reduced in 10 patients, 20% Schirmer's 2 measures the basal secretions only. This was reduced in 15 patients, and 20 patients had a reduced tear film breakup time. These observation indicates that reflex secretion was unaffected, but the basal secretion was more affected in psoriasis patient. The tear film instability was also seen in these patients due to increased meibomian gland function and blepharitis. So conclusion is ophthalmic complication of the psoriasis are numerous and affects almost all part of the eye. Dry eye and blepharitis were more common with psoriasis. Ocular manifestations are often non-specific or mildly symptomatic and not appreciated by both patient or physician. Hence, ocular manifestations of psoriasis may be missed in the absence of thorough ocular examinations. So therefore, routine eye examinations are recommended in psoriasis patients of all types to screen dry eye and regular follow-up visit with a dermatologist. Thank you.
Thank you very much, Uma. Shall we go to the next paper?
Sure, sir.
Yeah, Alisha.
I don't see that participant here.
Not there.
Yeah, I don't see.
Then what about Annie? Is Annie there?
Yes, sir, I'm there.
Yeah, you can share the screen. You can start then.
So my screen is visible.
Yeah, we can see. Start, yeah.
Good afternoon, everybody. I, Dr. Annie, fellow in oculoplasty in Narayan Nethralaya, Bangalore. This is a free paper, FP 813. My topic is use of anterior segment OCT to differentiate OSSN from its mimic. My chief author is Dr. Rashmi Gupta. Ocular surface squamous neoplasia refers to the entire spectrum of dysplastic, pre-invasive, and malignant squamous lesion of conjunctiva and cornea, characterized by gelatinous, papillary, and leukoplakic lesions with feeder vessels stranding limbus. OSSN is the most common non-pigmented malignancy of the ocular surface, closely resembling conjunctival and corneal surface pathologies like pterygium, allergic limbal nodule, hyperplastic epithelium, corneal scar, corneal degeneration. Because of its high potential to cause ocular and systemic morbidity, we do not want to miss the diagnosis of OSSN. Hence, it is important to differentiate OSSN from its mimic. Although histopathology remains the gold standard for definite diagnosis of OSSN, other investigation modalities for OSSN are slit lamp photo, non-contact, non-invasive anterior segment OCT, ultrasound biomicroscopy, confocal microscopy, impression cytology. Aim of this study was to see how well anterior segment OCT can differentiate squamous neoplasia from its mimic. We went back to the last 2 years and we selected 34 patients, which included OSSN case confirmed histopathologically or showed response to topical chemotherapy and whose ASOCT images were available, and non-OSSN cases whose ASOCT images were available to compare. ASOCT image of a normal cornea, which is usually studied with an ultra high resolution OCT, shows a hyperreflective tear film and normal thin hyperreflective corneal epithelium and stroma and hyperreflective endothelium. A typical ASOCT of an OSSN have certain characteristics known to be present, like surface hyperreflectivity, thickened epithelium, abrupt transition between the normal and abnormal epithelium, and backshadowing. We chose 19 OSSN cases and 15 non-OSSN cases. Without knowing the diagnosis, 2 observers tried to evaluate the ASOCT images to see if there is chance to differentiate OSSN from its mimic based on these characteristics. This is a case of OSSN. Anterior segment OCT show hyperreflective thickened epithelium with backshadowing. Another case of OSSN showing thickened epithelium and backshadowing and no surface hyperreflectivity. A case of actinic xerosis showing temporal raised keratinized lesion encroaching cornea, feeder vessel negative, conjunctival xerosis present. The anterior segment OCT shows surface hyperreflectivity, thickened epithelium, and backshadowing. A case of hyperplastic epithelium showing wide raised lesion on the cornea with no vascularity and feeder vessel. Anterior segment OCT shows a well-defined lesion at the epithelium with high internal density shadowing. A case of pterygium, patient presented with redness and pricking sensation. ASOCT showed no hyperreflective surface and lesion was well demarcated from the sclera. A case of juvenile xanthogranuloma showing yellowish limbal nodule in the subconjunctival extending into the cornea stroma, O-line epithelium intact. Anterior segment OCT showed low density, well circumscribed lesion deep intrastromal. Corneal furrow degeneration, anterior segment OCT do not show any hyperreflective epithelium. Epithelium is not thickened and there is no significant backshadowing. Sequelae of chemical injury. The epithelium is thickened, but low epithelial hyperreflectivity and significant backshadowing present. How anterior segment OCT images help in diagnosis of OSSN? We calculated the sensitivity and specificity of anterior segment OCT features and found epithelial thickening and backshadowing having high sensitivity. Hence, if we want to rule out OSSN, if epithelial thickening and backshadowing are absent, then most likely it is not an OSSN. High specificity was found for surface hyperreflectivity. Therefore, to rule in OSSN, if surface hyperreflectivity is present, then most likely the lesion is OSSN. Hence, anterior segment OCT can be useful to interpret to differentiate OSSN from its mimic. Thank you.
This is your retrospective study, is it?
Yes, sir.
So what made you to go in here? Any specific lead?
Pardon, sir?
Any specific lead that made you to do a anterior segment OCT in this kind of lesions?
Yes, sir.
No. What idea gave you this? I mean, what made you think of this? Because generally we look at it and then do a biopsy and we proceed.
There are many challenging mimics cases are there when we see on a slit lamp.
Yeah.
We want to rule out whether this is OSSN or is it not an OSSN, whether to observe, whether to do surgery, whether to put the patient on topical therapy.
Yeah.
Anterior segment OCT images help, although histopathology is the gold standard. Anterior segment OCT help in coming to the diagnosis.
Yeah, this is just an add-on to help you to come in there. So you're doing routine, is it, in case of suspected OSSN?
Yes, sir. We do in all cases.
Okay. Yeah, thank you. Uma, anything?
Nice, sir. Nice presentation.
Yeah, thank you.
Even though she also showed the pictures very well. I think it was a good presentation. Yes.
Yeah, true.
Thank you, sir.
Okay, can you have Faiza, the next presenter?
Hello, good afternoon, sir.
Yeah.
Are you able to present? Share this?
Yes, ma'am. I'm trying to share the PowerPoint, ma'am.
Okay.
Hello. Yes, ma'am. I'm sorry for that. I was trying to. Is my PowerPoint visible, ma'am?
Yes.
Yeah, it is. You can start.
Good afternoon, everybody. My name is Dr. Faiza Syed Jafar. I'll be presenting a paper on the effect of antidepressants on ocular surface disease. According to the International Dry Eye Workshop, dry eye disease is a multifactorial disease of the tear film and ocular surface, causing discomfort, visual disturbances, and tear film instability. Studies have suggested that there is a possible correlation between psychiatric disorders such as depression and anxiety and dry eye disease. This relationship may go both ways. Additionally, antidepressant medication itself has also been known to cause dry eyes. The relationship between dry eye disease due to antidepressant medication versus due to psychiatric disorder has not been well studied. So the aim of the current study is to assess the severity of dry eye disease in newly diagnosed anxiety and depression patients and correlate this to the severity of dry eye disease among those on chronic antidepressant medication. For this study, this is an observational case control study done over the period of 1 year. We examined 60 patients and a total of 120 eyes. We studied 3 groups of patients. Group 1 were the newly diagnosed anxiety and depression patients, and they gave no history of using antidepressant medication. Group 2 were patients on long-term antidepressant medication use for a minimum of 3 months. And group 3 were age and gender matched controls. All the patients were over the age of 18 years, and excluded patients were those that did not give consent, patients with systemic comorbidities, and patients with pre-existing ocular disease or any history of topical medication use. All the patients were subject to ophthalmic assessment, including visual acuity assessment, Schirmer's 1 testing, fluorescein staining, tear breakup time testing, and ocular surface disease index scoring. Psychiatric assessment was also done for group 1 and group 2 patients. These patients were selected after assessment by a psychiatrist was done, and they were categorized based on self-assessment questionnaires such as Hamilton Anxiety Rating Scale, HAM-A, and Hamilton Depression Rating Scale, or HAM-D. Now we'll move on to the results. It was noted that the majority of patients in our study were in the age group of 31 to 40 years of age, that is 40% of our patients, of which females were more common than males with a ratio of 3:2. It was found that all objective and subjective parameters of dry eye evaluation were markedly reduced in group 2 patients, that is patients on chronic antidepressants, as compared to group 1 patients, that is the newly diagnosed anxiety and depression patients, as compared to the control group. Ocular Surface Disease Index, or OSDI score, was predominantly normal in group 1 patients, that is the newly diagnosed anxiety and depression patients, as compared to group 2, those on chronic medication. Whereas the OSDI showed mild dry eye in 30% of group 1 patients, that is the newly diagnosed anxiety and depression. And in group 2 patients, it was seen that OSDI scoring showed moderate dry eye in 35% of patients and severe dry eye in 10% of patients. So OSDI was generally the lowest in the chronic group. For the most part, best corrected visual acuity was 6/6 in all patients in group 1, that is the newly diagnosed anxiety and depression patients, and in group 3, our control group. Whereas a noticeable percentage of patients in group 2, that is 15 to 25% of patients, had a best corrected visual acuity of 6/9. Again, these patients were the ones on chronic antidepressant medication. Coming to the correlation between the HAM-A and HAM-D and psychiatry disease scoring system, there was no significance noted between the subjective and objective parameters and the diagnosis of anxiety versus depression. There was also no significance seen between the subjective and objective parameters of dry eye disease and the class of antidepressant or the type of antidepressant that was used. In conclusion, from the study, we see that dry eye disease was subjectively and objectively most severe in those on chronic antidepressant medication as compared to the newly diagnosed persons of anxiety and depression, and this was still more severe than the control group. There was no noticeable difference in the grade of dry eye disease based on the class or the type of antidepressant that was used, and there was no noticeable difference between dry eye caused because of anxiety or because of depression. It can be inferred that psychiatric disorders such as anxiety and depression can cause dry eye disease, which may get aggravated with the use of oral antidepressant medication. Hence, it is advisable that all patients diagnosed with psychiatric illness also be prescribed topical artificial tear drops so as to prevent any undue complications. These are my references. I'd like to thank everybody for this opportunity. Thank you.
Yeah, thank you. I mean, my question is whether the disease causing dry eye or your medications are causing dry eye here.
So we found that the disease itself causes dry eye, but when we start on medication, it worsens the dry eye. So the OSDI scoring and the Schirmer scoring was much lower in those patients on medication, but it was still significantly low in those newly diagnosed anxiety and depression patients also, compared to the control group.
Yeah, because disease itself can cause dry
Yes,
eye
sir.
in them, and the medications also add on to that.
Yes,
Okay,
sir.
nice.
Thank you, sir.
Anything, Uma?
Yeah, good presentation. I wanted to
Thank
know
you.
what was the duration of follow-up?
We could not follow up these patients, unfortunately, ma'am. We tried initially to follow up these patients, but most of our patients did not come for follow-up. So it was a cross-sectional study we did, ma'am.
Okay, fine.
Thank
Yeah,
you.
that's it, sir. Yeah.
Can we proceed? Next is Kunal.
Hello,
Do we
sir.
have- Yeah, okay, you can start.
Sir, just a second. I'll share my screen.
Yeah.
Is my screen visible, sir?
Yeah, you can start.
Yes, sir. Good afternoon, everyone. This is a clinical study of blepharitis to evaluate the efficacy and treatment options in ocular demodex infestation. Introduction. Blepharitis is a condition that is characterized by the inflammation of the eyelid margin and a common cause of discomfort and irritation among people of all ages, ethnicity, and gender. The ectopic parasite Demodex is the most common parasite in humans. Demodex mites are present in 10% of the healthy people and can be found in 12% of their hair follicles. Many studies have reported that Demodex plays a pathogenic role in causing blepharitis, pityriasis folliculorum, papillopustular rosacea, and folliculitis. Demodex infestation is an often overlooked. The differential diagnosis in the clinical investigation of the blepharitis and may be the cause of treatment failure when not specifically assessed. Objectives of the study: to study the incidence of Demodex species in eyelashes in different types of blepharitis, to study the ocular clinical features of Demodex infestation, and to assess the efficacy of different treatment modalities in the management of blepharitis, including coconut oil, antibiotic ointment, and systemic ivermectin in patients tested positive for Demodex species. Materials and methods. The study design is a prospective interventional study. Sample size 70 patients with clinical symptoms and signs of blepharitis or non-specific irritations of the eyes during the night time were included in the study. The inclusion criteria was patient with the signs and symptoms of blepharitis of all age group, or non-specific irritations of the eyes during the night time, or previous systemic and topical treatment with no improvement in chronic blepharitis. The exclusion criteria is patients with the previous eye surgery or punctal occlusion, patients with contact lens wear or corneal infection or disease, and known hypersensitivity to ivermectin or pregnancy. Methodology: all the patients underwent a routine clinical ophthalmic evaluation, lid margin evaluation under diffuse light, followed by a slit lamp for the position and the number of the rows of eyelashes and any decrease in the number of lashes, presence of crust at the root and the shaft, dandruff-like material, meibomian gland examined for enlargement due to dysfunction, cyst, and expression of the secretion. Topical anesthetic, proparacaine 0.5% was instilled. Under slit lamp, lash sampling was done by epilation of 2 lashes per eyelid. A cover slip is mounted on the sample, and then normal saline is slowly pipetted at the edge of the cover slip to surround the eyelash using a micropipette. Lashes are then observed under 10x and 40x magnification of the light microscope immediately. Number of Demodex mites, morphology of the mites, and their movements are noted. Patients who are tested positive for Demodex mites are randomly selected for each of the following mentioned treatment strategies, in addition to the daily lid hygiene and artificial tear drops. That is, first is coconut oil application over the lid margin, twice for a day for a period of 4 weeks. The parachute oil was cultured for bacteria and fungus before and after sterilization with hot air oven, and no growth was seen. Chloramphenicol or other patients were treated with chloramphenicol plus polymyxin B eye ointment that is administered at the margins of the upper and lower lids, and lashes twice daily for 4 weeks. Then another was systemic ivermectin 200 microgram per kg body weight that was given stat, and another dose of ivermectin was given after 7 days. The follow-up was done at 1 month for improvement in symptoms and Demodex mite count under microscope. Results: the 70 individuals were enrolled in our study. Range of the age included in the study was 7 years to 85 years. Out of 70 patients, 35 were males and 35 were females. The Demodex incidence of Demodex infestation, Demodex was found to be positive in 27 individuals out of 70, that is 38.6%. The mean age was 59 years and it increased with age. Maximum incidence of Demodex blepharitis was found to be in the age group of 60 to 85 years. Demodex positivity with different types of blepharitis. So Demodex, 4 types of blepharitis, it was divided into 4 types, like meibomian gland dysfunction, mixed blepharitis, non-specific irritation, and anterior blepharitis. Out of the 21 patients with meibomian gland dysfunction, 13 patients had Demodex positivity that showed a p-value of significant p-value of 0.016. While out of 5 patients of mixed blepharitis, only 1 patient was Demodex positive. Out of 9 patients of non-specific irritation, 5 patients were Demodex positive, and 35 patients of anterior blepharitis, 8 patients were Demodex positive. Common symptoms and the relationship with the Demodex infestation. The most common symptom found with the Demodex infestation that was found in 38% of the patient, followed by burning sensation in 35% of the patient, and matting in the 30% of the patients. All the three symptoms can be associated with Demodex infestation, but none of them showed a statistically significant value. Common clinical signs in the relationship. All the symptoms were like crust or the dandruff, capping of meibomian gland, expression of the secretion like meibomian secretion like cloudy or opaque, tylosis, lid edema, and lid hyperemia, and madarosis were found in the patients with Demodex positivity. But capping of meibomian gland and madarosis were significantly associated with the meibomian gland, Demodex infestation. Clinical resolution of the symptoms after each treatment. So out of the 27 patients with Demodex positivity, 10 patients were treated with coconut oil, 11 with the chloramphenicol and polymyxin eye ointment, and 6 patients with the systemic ivermectin. Clinical symptoms resolution was seen in 90% of the patients with coconut oil, 63% of the patient with antibiotic ointment, and 66% of the patient with ivermectin. The p-value showed a value of 0.347 that was not statistically significant for any of the treatment. Demodex count before and after the different modalities of treatment. So in the coconut oil, the mean Demodex count before the treatment was 3.40, which reduced to 0.40, showing a statistically significant reduction of with p-value of 0.003. While all the three treatment reduced the only coconut oil reduced the Demodex count significantly. Discussion. In this study, the incidence of Demodex was 38.6%, that is 27 patients out of 70. Among the patients with Demodex positivity, meibomian gland dysfunction was significantly associated with Demodex infestation, followed by non-specific irritation. Demodex infested patients commonly complained of itching, followed by burning sensation. Demodex was significantly associated with signs like madarosis, capping of the meibomian gland. Treatment of chronic blepharitis caused by Demodex species is difficult and time consuming. Considering the mean and p-value, coconut oil is the first treatment option in the ocular demodicosis, as it improves the symptoms and reduces the Demodex count significantly, followed by antibiotic ointment and oral ivermectin as other treatment options. Conclusion. Demodex was associated with nearly half of the patients of blepharitis and also in patients with the chronic non-specific irritation. Demodex infestation evaluation should be considered in patients with blepharitis presented with itching and burning sensation. Coconut oil can be used as an alternative to the tea tree oil in treating ocular demodicosis, as it is easily accessible, cost effective, and has antimicrobial activity similar to the tree tea oil. Also, antibiotic ointment and systemic ivermectin can be used as other treatment options, but they are not as effective as coconut oil. Further research in a large number of patients about the diagnosis and treatment is the need of the hour. Thank you, sir.
Was there any association with pets and this Demodex infection?
Sir, in this study, exactly it was not studied, sir. Like whether there is an association. Like actually it is there. In other studies, they tell that Demodex is associated with, and there are different kinds of Demodex in the different mammals. Like Demodex affects most of the mammals.
Yeah. So basically, it's most of them have some pets and things like that. They can have this more of. How did you all diagnose this Demodex?
Sir, that for that lid sampling was done, sir. And okay. eyelid was sampled under slit lamp, sir.
You would see it under slit lamp?
No, sir. After that, epilation was done. Eyelid per lash, eyelash was sampled and then taken in a microscope, so light microscope, and sampled with 10x and 40x magnification, sir.
So done in the microbiology, or you guys did it?
No, sir. In ophthalmology department only we did it.
Okay. Uma, anything?
Yeah, I just want to ask, how do you explain the resolution of symptoms without reduction in the number of Demodex?
Sir, ma'am, in Demodex, count was reduced with all the 3 treatment group, ma'am. But it was significantly reduced with coconut tree, ma'am. Coconut oil, ma'am.
Yeah.
Count was
Okay.
yes, ma'am.
So in all the 3, there was a reduction in the, and the follow-up
Yes, ma'am.
period was 1 month.
Yes, ma'am. A 1 month follow-up, ma'am.
Okay. Probably if you follow up for a longer period of time, you would see whether the numbers would come down completely.
Yes, ma'am. Yes, ma'am.
Yeah, good study.
Thank
That's
you,
all,
ma'am.
sir. Yeah.
Yeah.
Thank you.
I think Alicia is there, no? Alicia, you would like to present now?
Yes, sir.
Yeah.
Good afternoon, sir.
Kunal, you can, yeah. Alicia can share the screen.
Yes. Sir, is my slide visible, sir?
Yeah, we can see it. Yeah.
Good afternoon. Myself, Dr. Alisha Rizvi. I'm a junior resident in the Department of Ophthalmology, KMC Manipal. I shall be presenting my paper on neonatal tear film protein analysis using high-performance liquid chromatography with LED-induced fluorescence. Chief author of this paper is Dr. Sulata Bhandari, Professor and Head of Department of Ophthalmology, KMC Manipal. And the co-author is Dr. Manali Hazarika, Associate Professor in the Department of Ophthalmology, KMC Manipal. Nil financial interest for any of the authors in this paper. This study is a prospective observational pilot study, single-centered study. IEC was obtained and registered with CTRI, 2-year study. The sample size of this is 80 neonates, includes 40 term neonates and 40 preterm neonates. The reflex and basal tear secretion systems are at very low levels in preterm infants, but increase with maturity. It is also known that non-invasive tear breakup time is prolonged and the lipid layer of the tear film is much thicker in the first 6 months after birth compared with the adult values. And this thick lipid layer in infants provides the stability that may prevent the thin aqueous layer from evaporating. Full-term neonates produce tears normally but have low spontaneous blink rates during the early life, which raise important questions regarding the tear dynamics and the stability of the tear film. The neonatal tear film is adapted to resist the evaporation-mediated tear film thinning, which presumably prevents drying of the ocular surface during long interblink periods. The low rates of tear turnover may have important implications for the defense of the eye against potential pathogens. The major tear proteins such as immunoglobulin A, lactoferrin, and lysozyme and lipocalin are involved in the ocular surface defense and the tear stability. The characteristics of the adult tear compositions have been studied continuously, but there is very limited information regarding the newborn's tear film. Hence, the objectives of my study is to qualitatively assess the tear film proteins in the Indian neonatal population, to assess the presence of any significant difference in the intensity of the tear film proteins between the two groups, that is term and the preterm neonates, and also to study specific proteins such that is expression of lysozyme and lactoferrin in the tear film of term and preterm neonates. The inclusion criteria included healthy term and preterm neonates without any ocular or systemic infection and excluded any baby with birth injury, any ocular injury or pathology, and those whose parents were not willing to participate in the study. The methodology includes the written informed consent was taken from parents, followed by a torchlight anterior segment examination. Under aseptic precautions in NICU settings, Schirmer strips were placed in the inferior conjunctival fornix of the left eye of the neonates for about 5 minutes. The wet Schirmer strips were then collected in labeled 0.2 ml Eppendorf tubes and then were transported in an icebox to the laboratory. There, the processing of the sample was done, which actually included the dilution of the samples with ionized water, followed by centrifugation. Then, if required, the samples were stored in -80 degrees Celsius and then were analyzed. The analysis including is basically the separation of the proteins from the samples. So that was done using a C8 column, which was a narrow bore column, which was then subjected to 278 nanometer LED to induce the fluorescence. It excited the proteins eluted through the column, and then the fluorescence was collected and digitally recorded as chromatograms. So this is, since we had 40-40 in each group, all 80 chromatograms were digitally recorded. 40 in each group, and then the average of the term and the preterm were taken out, and this is the average chromatogram of each of the term and the preterm groups. The red peaks, all these peaks, this is a graph of the intensity against time in seconds. The study was done for 40 minutes, hence 2,500-400 seconds. Here the red peaks are, all the peaks are depicting the protein elution. Different peaks are the different proteins. The red peaks are depicting preterm average chromatograms, and the black are the term. Here we can qualitatively see that there is a difference in the peak intensity between the term and the preterm group, which was then statistically analyzed using principal component analysis, which was done using a software that was Gram S32 software. Here all the mean chromatograms were first taken, and then the mean of that group with each sample in that group was taken, and the variation was then recorded as a variation spectrum. And this variation spectrum through the software using different algorithms depicted the difference. And here it is plotted, it's plotting that there is definite difference between the protein elution between the term groups and the preterm groups, depicted as in red and black color. The second objective was to study the specific proteins, that is lysozyme and lactoferrin, and for this co-injection study was done. So through using the setup of HPLC, first lysozyme and lactoferrin were separately analyzed to determine the eluting time of the proteins separately, lysozyme and lactoferrin, which was noted to be, lysozyme was noted to be around 1630 seconds and lactoferrin at 1650 seconds. So here we can see this is basically protein lysozyme chromatogram in term and preterm. So what we see here are, in the first graph on the left, we see that this is an intensity against time graph again, and we have three colored peaks. So the first is, the black one is the lysozyme. So first only lysozyme was subjected to HPLC setup to know the eluting time in order to identify the peak as a lysozyme peak, which is noted to be at around 1630 seconds. Following which term samples were processed and to know the general peak, and this peak was then co-injected in each sample to know the term tear fluid sample was then co-injected with lysozyme to know whether there is any increase in the intensity of the peak, which is here which is seen by the blue peak, which shows that there is qualitatively we can assess that there is a little bit of increase in the term tear fluid sample when lysozyme is added. Similarly, on the right side, it is the preterm, and here we see a lesser increase in the preterm peak after co-injecting the sample with lysozyme. So in protein lysozyme chromatogram of term and preterm, we see that there is a higher elution of lysozyme in term babies than in preterm samples. This is the lactoferrin chromatogram. Left side is the lactoferrin chromatogram in term samples, which is showing a definite increase in the after co-injection, and right side is the chromatogram for the lactoferrin co-injection in preterm samples, and we see a lesser increase as compared to the term samples. So here also lactoferrin is more was seen more in term samples than in preterm samples. So coming to the discussion, neonatal tear film samples collected using the Schirmer strip in the study were analyzed using high performance liquid chromatography with LED induced fluorescence. All 80 chromatograms were plotted, and the average values of term and preterm samples showed the difference in the intensity of the protein elution, which was found to be statistically significant using principal component analysis technique. All the other studies till date have used techniques like gel electrophoresis, Bradford assay, mass spectroscopy, which also give quantitative assessment. But HPLC LED induced fluorescence is a novel technique, and this is the first study using this method to detect the proteins. in tear films. Advantage of this is it includes a nanomolar detection sensitivity, which is nanomolar detection sensitivity. It is cost effective. There is an easy learning curve for the analysis, and once combined with spectroscopy or gel electrophoresis, we can also get quantitative data as well. Lysozyme and lactoferrin are two of the most abundant antimicrobial proteins in the tear fluid and play important roles in the innate mucosal defense. Using the co-injection technique, qualitative assessment of the two proteins in both the groups were seen in this study. The elution time for lysozyme and lactoferrin was noted to be at 1630 seconds and 1650 seconds respectively. It has been shown that tear proteins, both quantitatively and qualitatively, reflect the health of the underlying tissues and are useful for their evaluation in health and disease, as well as some systemic conditions. Therefore, in-depth analysis of healthy newborns' tear proteome will provide some baseline information that may help the researchers to monitor and assess newborns' eye conditions and diseases, as well as systematic complications. So on conclusion, the protein profile of term and preterm samples in the study showed difference in the intensity of the tear film proteins using the high performance liquid chromatography with LED induced fluorescence. Our system was able to detect lysozyme and lactoferrin in the two groups and also showed a significant difference between the two. Qualitatively, the study has concluded that there is significant difference in the expression of proteins in term and preterm neonates. The results of this study will help us to conduct more research to find out the significant factors for ocular surface change based on age, sex, and ethnicity in newborns and children to make a responsible conclusion on tear function or other ocular surface variables, and to study clinical and epidemiological factors for pediatric ocular surface disease as compared to the adult population. Thank you.
Thank you. Is there any difference between adult and preterm or not preterm, term babies?
So there is a difference, sir. Immunoglobulin is found to be more in the term babies, as whatever studies were there quantitatively.
Compared
Whereas,
to adults?
Lysozyme and yes, sir, and lysozyme and lactoferrin were also more in adult population as compared to children, sir.
Okay, you're done basically term and preterm. This
Yes,
study?
sir. 40 terms and 40 preterms, and then compared there, but it is a qualitative study, sir.
Okay, okay, yeah. Uma, any?
No questions, sir.
Rashmi has joined.
Presentation.
Rashmi has joined or no?
Yes, sir, I have joined.
Okay. Okay. Yeah. Yeah, I think we can go to the next one. Dr. Pallavi?
Yes, sir.
Yeah, you can see it. Yes.
Okay. Is it my screen is visible, sir?
Yeah.
Okay. Good afternoon, everybody. I am Dr. Pallavi from Kempegowda Institute of Medical Sciences, Bangalore. I'll be presenting ocular surface squamous neoplasia case in a young female. Coming to introduction, OSSN is one of the most common ocular surface neoplasias. It encompasses spectrum of precancerous and cancerous epithelial lesions of conjunctiva and cornea. The spectrum includes dysplasia, conjunctival intraepithelial neoplasia, and invasive squamous cell carcinoma. Lee and Hurst first proposed the term ocular surface squamous neoplasia in 1995. So coming to the case, here is the patient who is 30-year-old female with no comorbidities. Complaints of a nodular swelling in the right eye surface since 3 months. The lesion was gradually progressive in nature and there was sudden increase in the size in 2 weeks. On examination, visual acuity in both eyes was 6/9. There was a gelatinous nodular limbal lesion at 4 o'clock position of size 3 × 3 millimeters. It had irregular surface and keratin deposits were present on the lesion. And we can see it is invading into the cornea also. On examination, there was also tortuous feeder vessels, and there was positive lysamine green staining. This is the staining which stains the dead epithelial cells. So we evaluated the patient and then posted for surgery. During surgery, peribulbar block was given. 4 mm conjunctival margin was marked around the lesion. Then en bloc dissection of the lesion with 4 mm conjunctival margin was done without touching the tumor. Then the instruments were changed. So this was done using one-touch technique, and to the corneal surface, alcohol epithelectomy was done. Absolute alcohol was used. Then double freeze thaw cryotherapy was done for the conjunctival margin. Then conjunctival limbal autograft was taken from the superolateral surface. Then conjunctival surface was sutured to the conjunctiva, and the limbal surface was sutured to the limbus. Later, amniotic membrane grafting was done, covering both cornea and the conjunctiva. Histopathological examination showed the presence of stratified squamous epithelium and also hyperkeratosis, parakeratosis, and full thickness dysplasia. There was presence of areas of hemorrhage and also desmoplastic stroma. And typical keratin squamous pearls were seen. Similar study was done in our institute in June 2019 about the ocular surface squamous neoplasia cases. It was concluded that ocular surface squamous neoplasia is classified into pre-malignant conjunctival intraepithelial neoplasia and malignant invasive carcinoma with higher incidence of conjunctival intraepithelial neoplasia compared to invasive lesions. It is important to pick up the suspicious lesions and initiate early management, though there are no non-recurrence rate is less than 5% and regional metastasis is also less than 2%. OSSN generally has a good prognosis except in mucoepidermoid, spindle cell variants, and immunocompromised patients. So this was the patient picture before the surgery, and after surgery, the ocular surface was restored to normal. Thank you.
Thank you. It's a good case study. Can you proceed to the next one? Next is Rachna. Uma, you could say something?
Yes, I just wanted to know what was the duration of follow-up, but then it's fine, I think. We can go to the next presentation.
Yeah.
It was 6 weeks, ma'am.
Okay, thank you.
But still we are following the patient
Sure.
to see for any recurrences.
Sure.
Thank you.
Next presentation.
Rachna.
Yes, sir. I'll share my slide. Good afternoon, sir. Good afternoon, ma'am. Hello.
Yeah, we can hear you. Proceed.
Okay, ma'am. Okay, sir. Good afternoon, everyone. My paper presentation for today, the topic is intraoperative versus postoperative mitomycin C role in primary pterygium treatment. Introduction. A pterygium is a wing-shaped growth of fibrovascular conjunctival tissue encroaching onto the cornea. It is seen worldwide with a high prevalence in the pterygium belt between 30° north and south of the equator. It most commonly affects individuals who are exposed to the outdoor environment, especially to the dry, dusty, windy environment, and also long-term exposure to the UV radiations. Indications for surgery is the treatment of choice for primary for pterygium, and indications for surgery are cosmetic reasons, reduced vision due to encroachment of pterygium on the visual axis, irregular astigmatism, recurrent inflammation, restriction of ocular motility. Recurrence of pterygium may occur following surgery with almost recurrence rate of 30 to 70%. So to overcome the recurrence, various adjunctive treatment modalities have been recommended for both advanced primary pterygium and secondary recurrent pterygium, like application of mitomycin C, thiothepa, 5-fluorouracil, beta irradiation, and then application of bevacizumab, cyclosporin drop instillation, laser therapies, and surgical excisions with conjunctival flap or conjunctival limbal autograft and amniotic membrane transplantation. So the aim of the study is to compare the recurrence rate between the intraoperative and postoperative application of mitomycin C in pterygium excision with conjunctival limbal autograft, and also to assess the safety of mitomycin C in surgical management of primary pterygium in terms of adverse effects of the drugs. So the methodology, this is a prospective interventional comparative study, which included 30 eyes of 27 patients with primary pterygium at Saptagiri Institute of Medical Sciences and Research Center, Bengaluru. And all patients were thorough ophthalmic examination was done. The inclusion criteria for this study was all the age between 80 to 70 years, and only primary pterygium cases were included, and patients willing to give the consent for this procedure, for the study, and as well as who are willing to come for follow-up. And exclusion criteria were patients with autoimmune disorders such as rheumatoid arthritis, collagen muscular disorders, herpes simplex keratitis, and concurrent acute uveitis, patients using any immunosuppressive drugs, and those who had past ocular surface and adnexal surgeries, and any contact lens users, dry eyes, and recurrent pterygium type was not included in the study. And so all the patients underwent pterygium excision with conjunctival limbal autograft. Patients were divided into 2 groups each. Group A received adjunctive topical 0.02% of MMC intraoperatively, and Group B received 0.02% MMC eye drops postoperatively, 1 drop twice daily for 5 days after pterygium excision. And all patients were followed for recurrence, that is a fibrovascular growth extending more than 1 mm across the limbus onto the cornea for a period of 6 months. This was a surgical technique that we followed in our hospital for this particular study, where after dissecting the pterygium head from the underlying cornea, intraoperative 0.02% of MMC was applied subconjunctivally for 3 minutes, after which almost 40 ml of thorough saline wash was given. And then later on, the subconjunctival tissue was separated and excised from the conjunctiva. Later on, the inferobulbar conjunctival limbal autograft was harvested and placed over the conjunctival defect area. We made sure that limbus to limbus orientation was maintained, that's it. And we had to wait for another like 5 minutes so that the graft would have been nicely adhered to the defect area, in the defective area. And this was a photo of POD1, like post-operative day 1, where we can see the conjunctival autograft, which is there inside too. And this was the place where we can see the inferotemporal conjunctival limbal autograft was taken. Results. In our results, we saw that it was more prevalent in 40 to 49 years of patients had presented more, had highest presentation, and it was more commonly seen in males than in females, and it was seen more in outdoor workers than the indoor workers. And the complications were in patients with the intraoperative mitomycin C application group, we saw 1 case of graft edema, 1 case of graft displacement or recession, and that's it. Whereas in postoperative drop application group, we saw two cases of graft edema, 1 case of graft displacement, and 1 case of recurrence, and 1 case of tenon cysts. We can see the tenon cyst here. Here we can see that the graft is receded back, recession is seen, and this was the graft edema, which we can see here. So discussion. For pterygium, surgery is the mainstay of treatment of pterygium, And the primary concern is recurrence, that is regrowth of fibrovascular tissue across the limbus and onto the cornea. Generally, pterygium recurrence happens during the first 6 months after surgery. Factors such as the type of pterygium, age of the patient, environmental agents, and surgical technique may be responsible. So in our study, we compared intraoperative and postoperative 0.02% of MMC application following pterygium excision with conjunctival limbal autograft. No significant difference was noted. The p-value was not that significant. So we found a recurrence in one case, that is 3.3% in group B, in postoperative 0.02% of MMC application. And a similar results were found in Gupta et al., Zaki et al., and Othman et al. So the advantage of this technique is the inferobulbar conjunctival graft is, so the graft is taken. So the superior bulbar conjunctiva is spared, which can be used in future filtering surgeries in such eyes. And it was a glue-free technique, and so it was a cost-effective technique. And limitations are there were only small sample size and short duration of follow-up period. Conclusion: intraoperative and postoperative 0.02% MMC application in the treatment of pterygium, primary pterygium are equally effective and safe, as there was no much difference in the recurrence rate between the two groups. But pterygium excision with conjunctival limbal autograft with intraoperative 0.02% application is a better technique, as it is a simple, effective, least toxic, and independent of patient's compliance. These are my references, and thank you, sir. Thank you, ma'am.
Thank you. What is the age group you did this technique in? What is the mean age?
Sir, mean age was 40 to 49, sir. We saw more commonly in 40 to 49 years. That was 38% of the patients were in this age group. Second highest was in 50 to 59, and then 30 to 39 age group, sir. And more bilateral presentation we saw than unilateral. We did see unilateral, but more of bilateral we got. We saw patients. Walked-in patients we selected.
You did it for all the patients, or you selected some patient for this technique?
No, sir. Whoever was willing and was ready to participate in the study, and who was willing to allow us to apply mitomycin C, we selected those patients.
No, indicate, because we need to prevent recurrence, but there are other techniques also. So
yes, sir. Yes, sir.
Yeah. Rashmi, Uma, anything?
Yeah. How many of your cases were bilateral?
That one, ma'am.
And did you see a difference in the two eyes?
Ma'am, some were like very progressive, some were not that progressed. They were just starting. They were not of equal size when it was bilateral. Even though it was bilateral, it was not always of the same size. It was of different sizes. The numbers, I didn't put it here, ma'am.
Okay, that's fine.
Thank you.
Why did you apply mitomycin in primary pterygium?
Ma'am, even though there are few studies where adjunctive treatment always reduces the recurrence rate. So we want to see whether applying it only, whether it will, it's already established that applying mitomycin C does reduce, but we wanted to know whether intraoperatively it will reduce, or whether the postoperative application also is equally effective or not. So we found it was almost, we got only one recurrence out of 30 patients. Like out of 15 patients of post-operative application, we got only one patient, ma'am. So that too, because the age of the patient, she was quite young. She was only 42 years, and it was in the second month she had recurrence. Otherwise, rest all, none of them had any recurrence. So we feel like intraoperative application was a better one, because we make sure that we apply for a few minutes and then we give a thorough wash. Whereas in post-operative applications, patients can overuse the drugs, or maybe they can apply it very rarely. They might not apply it as how we advise. So that can lead to the toxicity.
Go to next presentation, please.
Okay, thank you, ma'am. Thank you, sir.
Okay, thank you. Shall we proceed now next to Reshma?
Yes, sir.
Yeah.
Today I'm presenting a comparative study on corneal endothelial cell density in different grades of dry eye. Chief author is Dr. Ravindra Bankar. Dry eye disease is one of the most common ophthalmic conditions affecting 5 to 35% of general population. Although it is traditionally considered as a disease of ocular surface and tear film, recent studies show more extensive involvement of cornea and conjunctiva. Dry eye is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film, accompanied by the ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. In dry eye disease, the thickness of cornea is significantly reduced and decreased density of epithelial cells and subbasal nerves were reported. In severe dry eye disease, irregular subbasal nerve branches are observed. Corneal nerves have been shown to be decreased in dry eye disease in different studies. Objectives of my study are to study the following characteristics of corneal endothelial cells in patients with dry eye disease. They are central corneal thickness, corneal endothelial cell density, average cell size, hexagonality, and to correlate the corneal endothelial cell changes with severity of dry eye disease. Materials and methods. Source of the data were patients attending OPD in the Department of Ophthalmology. Study design. It is a cross-section hospital-based analytical study. Sample size. A total number of 120 eyes were studied. Inclusion criteria. Patients with typical symptoms of dry eye disease are included in the study. Exclusion criteria. Patients with history of previous contact lens wear, history of use of any medications known to have corneal toxicity, previous ocular surgery or injury, corneal disease including herpetic keratitis, ocular allergic and surface diseases, glaucoma, diabetes mellitus, subjects with systemic or ocular treatment. Methods. 120 eyes of 60 patients with dry eye disease are divided into 3 groups, mainly based on the OSDI score into mild, moderate, and severe. In these 3 groups, first group comprised of 40 eyes with mild dry eye, group 2 comprised of 40 eyes with moderate dry eye, and group 3 comprised of 40 eyes with severe dry eye. All subjects will underwent a complete ophthalmic examination, which includes visual acuity, refraction, intraocular pressure measurement, slit lamp biomicroscopy, and fundus examination. Along with that, dry eye test, including tear breakup time and Shermer's test with and without anesthesia were performed. The corneal endothelial structure will be examined in all patients by non-contact specular microscopy using TOMI EM 3000 specular microscope. It was done by a single examiner. The endothelial morphology was evaluated for a variety of factors such as corneal endothelial cell density, central corneal thickness, average cell size, hexagonality, and coefficient of variation. This is a specular microscopic image of corneal endothelium in a severe dry eye disease patient. In this, we can see the central corneal thickness is 512 and the results. The endothelial cell density in different grades of dry eye is as follows in our study. In group 1, the endothelial cell density was 2540. In group 2, it was 2545. And in group 3, it is 1888. This is a graphical representation of endothelial cell density in different grades of dry eye. We can see that in group 3, the endothelial cell density is decreased when compared to group 1 and group 2, that is mild and moderate. The mean endothelial cell density was significantly lower in subjects with severe dry eye than moderate and mild dry eye subjects. P-value was 0.001. Discussion. There is significant reduction in the endothelial cell density in severe dry eye disease compared to moderate and mild dry eye disease. Our results were similar to a study conducted by Kerka et al., in which eyes with dry eye disease displayed a significant reduction in corneal endothelial cell density that correlates with the clinical severity of the disease. Conclusion. Endothelial cell density showed significant correlation with clinical severity of the disease. That is, in severe dry eye disease, the endothelial cell density was significantly low when compared to the mild and moderate dry eye disease. Thank you.
Any one of them had undergone surgeries, intraocular surgeries?
Pardon, sir?
Any of your patients you've done a study on, have they undergone any surgical procedures before that? Any intraocular surgeries?
I didn't include that, sir. That is in exclusion criteria.
So they excluded it, right?
Yes.
And
yes.
what about the age? With the low endothelial count, what are the age? Any idea?
Sir, according to the normal endothelial count, according to age, I have compared in the study, sir. Like according to their age only, I have compared and measured it.
So your age group was from where to where? What is this one? The range? Have you done that?
Age group I took from 20 to 50 years, sir.
Okay. Because the endothelial cell count also can vary according to the age.
Yeah, yes, sir. Yes, sir. Yes.
Okay. Yeah. Rashmi and Uma, any?
Nothing more, sir.
Okay, we can proceed then. Next.
Yeah, I want to ask, why do you think endothelial cell density will decrease in dry eye disease? What is the mechanism here?
Ma'am, like it should be elucidated still, but in some studies they have told that the corneal nerve density was decreased.
Okay.
Because of the inflammation of the dry eye related inflammation, the density was decreased, and so corneal endothelial cell count was decreased in they have given, ma'am.
Okay. Did you exclude diabetics and any other medications, all those things?
Yes, ma'am, I have excluded.
Okay.
Diabetes, glaucoma, and everything I have excluded.
Okay. We'll
And
move
she's
on.
got only one more study, I think so. She's referred.
Yes, only one study. Yes.
Yeah.
Yes.
Okay. Yeah.
Yes.
Next is Santosh.
Yes, sir.
Yeah.
My slides are visual, sir.
Yeah. You can proceed.
Yeah. Okay, thank you. Title of my study is Impact of Acute Emotional Stress and Quality of tear film in exam-going postgraduate medical students. The co-author is Dr. Pradeep A.V. There is no financial interest. Introduction: medical education is more intensive and longer compared to other courses, so it is not surprising that these students experience greater risk of anxiety and stress-related comorbidities. However, it is not only health consequences that pose a problem, as there are also other implications that may impact a young person's future, such as academic performance, and may be aggravated in the presence of tear film disorders. Tear film stability is threatened when the interaction between the tear film stabilizing constituents are composed by decreased tear secretion, delayed clearance, and alteration of film breakage. Eye surface inflammation is a secondary consequence of this dysfunction. Reflex tear secretion is seen as an initial compensatory mechanism, but over time, inflammation accompanying secretory dysfunction and decreased corneal sensitivity eventually compromises the reflex response and results in greater tear film instability. Disruption of tear function unit plays an important role in ocular surface lubrication. At the 2007 International Dry Eye Workshop, the definition of disease was revived and rephrased as follows. Dry eye is a multifactorial disease of tears and ocular surface that results in symptoms of discomfort, visual disturbance, and tear film instability with potential damage to the ocular surface. It is accompanied by increased osmolarity of tear film and inflammation of the ocular surface. Basically, dry eye is disturbed homeostasis of tear film maintained by subtle neurological and hormonal mechanisms. Objectives of my study: to observe the occurrence of dry eye related to acute emotional stress and to assess the severity of dry eye with severity of the stress. Materials: it is materials and methods. My study is a hospital-based observational study. Study area is outpatient department of ophthalmology. Sample size 40 subjects. Study was conducted between July 2021 to October 2021. Study subjects are classified in the following groups as per severity of stress based on standard perceived stress scale. Group A with a stress scaling of 6 to 14, that is mild. Group B is moderate with a score of 15 to 24, and Group C is severe with a score of 25 to 40. Inclusion are exam going final year postgraduate student. Exclusion criteria: participant not willing to give consent and participant with existing ocular conditions. The subject to complaints and symptoms was evaluated with ocular surface disease index questionnaire and visual acuity, slit lamp examination, Schimmer test 1. Tear breakup time was done to all subjects 1 week before the start of final academic year examination and 35 days after the end of examination. The results: there were 40 students, among them 22 were in the category of A, 10 in category B, and 8 in category C. And in category A, there were 9 subjects with dry eye and in category B 6, and in category C 6. And a mean ocular surface disease index score in category A was 26.5, category B was 27.9, and in category C it is 38.8. Mean tear meniscus height in millimeter in category A before examination was 0.6, and after examination it was 0.8. And in category B, before examination, it was 0.5, and after examination, it was 0.7. And in category C, before examination, it was 0.4, and after examination, it was 0.8. Mean tear breakup time in study group, category A, before examination, it was 16, and after examination, 20. And in category B, before examination, it was 12, and after examination, it was 16. And in category C, before examination, it was 8.5, and after examination, it is 16.5. Mean Schirmer test 1 value in a category A before examination 15.5, after examination 22.5, and in category B before examination it was 12, and after examination it was 19, and in category C before examination it was 6, and after examination it was 4 millimeters. Conclusion: there was decrease in the breakup time and Schirmer 1 test value before academic examination, and improvement was seen after few days of examination, which was statistically significant. However, there is no correlation between stressful parameters caused during this period, and also it was easy to return to baseline after examination. This scientific information is of great relevance for the psychological support for the medical student before taking academic examination. Thank you.
Very interesting study, man.
Awesome.
This why do you think only emotional stress in postgrad medical students? You don't think others have emotional stress?
Most of the students will experience stress during their academic examinations. So that may be from SSLC to the post-graduation or any DNB examination.
No, because your title says postgraduate medical student, so I thought others are stress-free.
In post-graduation, it will be more.
What is it? Now, you did this study on which students now? Any particular branch?
My seniors.
So, have you finished your exam or no?
No, sir, no.
Not
no,
yet. Okay. No. So you are the next subject. And so, did you check how many times they blink? The blink rate did you check?
Rate I didn't check, but I studied mainly on Schirmer 1 values and tear breakup time. And tear meniscus height, sir.
Okay. Yeah. Okay.
How do you account for this? That they also read a lot, no, before exams. So that could also be responsible for dry eyes. More screen time, reading time, screen time.
And they blink less.
Yes.
Blink less. But most of the time they have adequate sleep, sir. Then also they have some amount of stress. And
okay.
Shall we proceed next?
Okay, thank you, sir.
Yeah, thanks. Next is Kangu Jam.
Yes, sir.
Yeah, you can.
Sir, am I audible, sir?
Yeah, we can hear you. You can see the screen also, yeah.
Good afternoon, sir. Good afternoon, ma'am. My topic is on computer vision syndrome associated risk factors among undergraduate students in a medical college in Bangalore. Coming to introduction, computer vision syndrome is defined as a complex of eye and vision problem resulting from the activities which stress the near vision during the use of the computers and digital screens. Vision affection results from interaction with digital screen, computer display, or their environment. In addition, computer vision syndrome can also be explained by decreased blinking reflex while staring at the screen, leading to exaggerating dry eyes. Common symptoms include eye strain, headache, blurred vision, as well as neck or shoulder pain that often increases in severity with the amount of video display terminal use. The increased use of digital screens not only increases the odds of developing computer vision syndrome, but also occupational overuse syndrome. It is an injury to fingers and wrist caused by repetitive movements, headache, as well as psychosocial stress. In fact, it is estimated that around 60 million people suffer from CVS globally, and that 1 million new cases of CVS occur annually. Nowadays, university students, including medical students, are spending more time staring at the screen for studying or for research work. There have been several studies reporting an increased prevalence of CVS among computer users, especially medical students. My objective is to detect the prevalence of CVS associated risk factors, Most common symptoms among medical students in Rajarajeshwari Medical College and Hospital, Bangalore. This is a cross-sectional observational study which was done in a 2 months period. It was done by online survey conducted among undergraduate medical students aged between 18 to 26 years who had agreed to participate. Questions were designed regarding computer vision syndrome, associated risk factors, and common symptoms. Responses were collected and analyzed. My sample size is 250 according to this formula, and the inclusion criteria are those students who had agreed to participate at age between 18 to 26 years, and exclusion criteria are those students who have not given consent and age below 18 years and above 26 years. Coming to results, the table number 1 showing socio-demographic profile of the participants, in which out of 423 participants, 263 were female and 160 students were male. Age of participant ranged from 18 to 26 years, average being 21 plus minus 2 years, out of which maximum participants were from third year MBBS. Figure number 1 shows participants who are aware of CVS. Out of 423 participants, 245, that is 58% students are aware of CVS and 42% students are not aware of CVS. Figure number 2 showing common ocular symptoms reported by the students. Most common ocular symptoms being watering of eye, which is 27.66%, followed by eye strain, increased sensitivity to light, headache, eye irritation, redness, and blurred vision. Figure number 3 showing extraocular symptoms reported by the symptoms. Most common extraocular symptoms being neck pain, which is 24.35%, followed by back pain, shoulder pain, and joint pain. This is the showing digital devices uses habits among medical students. Most of the students use a digital screen, which less than arm length distance, and maximum number of student uses brightness level of 51 to 75%, and more than half of the students use the center of screen at equal to the eye level, and 51% of the student takes break within 0 to 30 minutes of break during the study, and maximum number of student uses screen time of 3 to 4 hours per day. This first figure number 5 shows prevalence of computer vision syndrome with age and sex. I have divided 3 age group, which is first is 18 to 20, 21 to 23 years, and 24 to 26 years. The prevalence of computer vision syndrome is showing more between the age group of 24 to 26 years, and prevalence with sex, female are showing more of computer vision syndrome symptoms. Figure number 7 shows relation between the hours spent on digital devices and computer vision symptoms. Those students who use screen time more than 6 hours per day, those students are showing more of computer vision symptoms, which is 81.97%. Coming to discussion, among the 423 students enrolled in the study, high prevalence of CVS was observed in which 388 of them, which is 91.72%, reported at least one symptoms of CVS during studying using computers, out of which 263 were female and 160 were male. It is accordance with a study by Hassan et al., who reported a prevalence of 90.5 among medical students in Pakistan. Reddy et al. Also provided a prevalence of 89.9 among university students in Malaysia. In regard to gender, females were observed to have more risk of CVS. Among 263 females, 194 females have computer vision syndrome. This association agrees with the findings by Gillen and Masia, who studied the effect of gender on tear film evaporation, which showed a significant high evaporation rate in females, thus higher risk of computer vision syndrome. The most frequently reported ocular symptoms were watering of eye, followed by eye strain. Other ocular symptoms were also reported. Those are sensitivity to light, headache, irritation, redness, and blurred vision. Among the extraocular symptoms, neck pain was the most common symptoms, followed by back pain and shoulder pain. Our study shows that the duration of studying using computer was the most significant risk factor, in which among 61 students who used digital screen for more than 6 hours per day have severe symptoms. The Logaras et al. Also reported that among serious positive group, students who had spent more than 4 hours were significantly at higher risk of CVS than who spent less than 4 hours. Coming to conclusion, computer vision syndrome is very common among undergraduate medical students, with watering of eye and neck and back pain being the most common symptoms. Our study has shown that the development of computer vision syndrome is associated significantly with the following risk factors. Those are female gender, longer duration of computer use, distance from the screen, and higher brightness of the screen. As universities continuously develop their educational method, there is a need to raise awareness among students regarding health effects related to prolonged computer use for studying and explain preventive measures in order to reduce the computer vision syndrome. These are my references. Thank you.
Thank you very much. I think now CVS is across everybody, not only medical students. Post-COVID,
Yes,
I think it's
Yes,
it's all across. So we
Yes.
have to live with we have to live with it. We have to teach them how to manage.
Yes, sir.
Yeah. Rashmi and Uma, anything?
No questions, sir.
Yeah, we'll proceed to the next one. Oh, Rashmi is saying something.
No questions, sir.
Okay, yeah. We'll proceed to the next one, right? Next
Thank
is the yeah, thank you. Shivani?
Yes, sir.
Yeah.
Can you see my screen, sir?
Yeah, we can hear you also. Yeah.
Good afternoon, everybody. Today is my paper presentation on distribution of dry eye disease in type 2 diabetes mellitus patients with and without dyslipidemia. Starting with the introduction, as we know, diabetes mellitus is a systemic disease which can cause a variety of ocular complications like diabetic retinopathy, cataract, glaucoma, and dry eye. Along with diabetes, dyslipidemia is also becoming a serious public health problem, and it is considered one of the most significant modifiable risk factors for cardiovascular diseases. Dry eye disease is a multifactorial disorder of tears and ocular surface. It was defined by International Dry Eye Workshop as changes in the quality or quantity of tears or changes in the dynamics of the tear film, which can lead to disturbances in the vision and which will lead to the involvement of the infection of ocular surface. Previous studies have reported an increased prevalence of dry eye in diabetic and dyslipidemic patients separately. They have also found common dry eye symptoms in these two patients separately. So this suggests that the examination of dry eye should be an integral part of ocular examination in patients with type 2 diabetes mellitus as well as dyslipidemia. So in the current study, we are looking for the prevalence of dyslipidemia and dry eye disease in controlled and uncontrolled type 2 diabetes mellitus patients. And we are trying to identify the association between dry eye disease in diabetes mellitus patients with and without dyslipidemia. So aim of my study is to study the distribution of dry eye in type 2 diabetes mellitus patients with and without dyslipidemia. Coming to the methodology, it is a descriptive cross-sectional study conducted in the Department of Ophthalmology in a tertiary care center between the time period of April 2021 to September 2021 with the sample size of 30. We included all to type 2 diabetes mellitus patients who were aging more than or equal to 40. Patients having history of eyelid surgery or ocular surgery within last 6 months, conjunctival diseases, refractive surgeries, who are having history of chemical injuries or any using any topical ocular drugs, topical tear supplements, any systemic diseases, or who have a history of or currently on any treatment for dyslipidemia like statins were excluded from the study. Coming to the diagnostic criterion, patients were divided into controlled and uncontrolled type 2 diabetes mellitus depending upon their HbA1c values. Then each group was divided into normal lipidemia or dyslipidemia depending upon their total cholesterol, triglycerides, HDL and LDL levels. Then dry eye disease assessment was done depending upon the presence of DED symptoms like itching, foreign body sensation, watering or redness. Then tear film disturbances were diagnosed by using T-Butt and Schirmer's first test. And conjunctival and corneal damage was assessed by using a rose Bengal staining of ocular surface and corneal fluorescence staining respectively. While collecting the data, depending upon the frequency and severity of signs and symptoms, visual disturbances, corneal staining, ocular staining, T-Butt and Schirmer's, and depending upon the OSDI score based on OSDI questionnaire given by patient, all patients were divided into 4 dry eye groups like normal, mild, moderate, and severe. Coming to the results of my study, it was a cross-sectional study conducted among 15 subjects of controlled and 15 subjects of uncontrolled type 2 diabetes mellitus patients. And we did assess their fasting lipid profiles. So coming to the controlled diabetes mellitus group, in normal lipidemia group, majority of subjects had mild dry eye with a percentage of 87.5. And dyslipidemia group had moderate dry eye with a percentage of 85.7. Coming to the uncontrolled diabetes mellitus group, normal lipidemic patients had moderate dry eye with a percentage of 62.5. And patients who are having dyslipidemia in this group had severe dry eye with a percentage of 71.4. This is the table 1, which is showing the study population. Here, with controlled and uncontrolled type 2 diabetes mellitus with their grading of dry eye is shown, and this is a table 1B, which shows the distribution of dry eye with normal lipidemia and dyslipidemia and controlled or uncontrolled type 2 diabetes. As you can see in this table, as you can see in these 2 columns, there was a significant difference in the total cholesterol and triglycerides, especially among the dyslipidemic patients in the uncontrolled type 2 diabetes mellitus patient. P-value was significant in this group. Starting with the discussion, the mean age in the control group was 60 plus minus 4 years, and that too in uncontrolled diabetes mellitus group, it was 62 plus minus 4 years. According to the results, we found that controlled diabetes mellitus patients in normal lipidemia, they had mild dry eye, and dyslipidemia, they had moderate dry eye. In uncontrolled group, normal lipidemic patients had moderate dry eye, and dyslipidemic patients had a severe dry eye. According to the previous studies done by Jean et al., they also found that type 2 diabetes mellitus patients usually suffer from tear film dysfunction, which is consistent with this study. And since we included all diabetic patients, one prospective cohort study showed that the prevalence of high triglycerides and LDL increases with the increasing severity of MGD, and which can cause dry eye. Also, Taiwan population-based study showed that the prevalence of hyperlipidemia was significantly higher in patients with dry eye. In the current study, there was a statistical significant difference in the total cholesterol and triglycerides among dyslipidemic patients of uncontrolled type 2 diabetes mellitus patient, which showed more severe dry eye. Thus, dry eye should be evaluated in all diabetes mellitus patients along with their fasting lipid profile status. Coming to the conclusion, since we know by the results that uncontrolled diabetes mellitus patient along with dyslipidemia had more severe grade of dry eye, hence the examination of dry eye should be an integral part of ocular examination in type 2 diabetes mellitus patients as well as dyslipidemic patients. These are my references. Thank you.
Thank you very much. Rashmi and Uma, anything?
No, sir, it's a good study.
Yeah. Okay. Okay. You can proceed to the next one.
You, sir.
Yeah. Thank you.
Sir.
Thank you. Shall we have Varshita?
Yes, sir.
Yeah.
Hello, sir. Yes. Sir, are my slides visible?
Yeah, we can hear you also. Yeah.
Good evening, everybody. Today, I'm presenting my paper on the outcome of pterygium surgery following excision with superiotemporal versus inferior limbal conjunctival autograft. Introduction. Pterygium is a triangular wing-like growth consisting of conjunctival epithelium and hypertrophied subconjunctival connective tissue that occurs nasally and or temporally in the palpebral fissure and encroaching onto the cornea. Surgical excision is the main modality for treatment of pterygium, and although pterygium excision followed by a superior conjunctival autograft has a low recurrence rate, it could compromise the results of future filtration surgery. By using an inferior conjunctival autograft, the superior conjunctiva could be preserved for future surgeries when required. Objectives: to evaluate the efficacy of use of inferior limbal conjunctival autograft for the treatment of primary pterygium, and to compare the complications and recurrence rate of pterygium after superiotemporal clag versus inferior clag, and as well as to assess patient comfort following either method postoperatively. Materials and methods. The source of data were patients with pterygium presenting to the ophthalmology department in Bapuji Hospital and Chikateri Hospital, Davangere. The study design is interventional, prospective, and comparative study. And sample size was 60 patients who fulfilled the inclusion criteria and gave informed consent willingly were included in this study. The inclusion criteria was age more than or equal to 20 years and patients with primary pterygium. Exclusion criteria: recurrent pterygium, other ocular diseases like scleral ulceration, conjunctivitis, corneal edema, uveitis, or glaucoma, major systemic diseases like collagen vascular diseases, uncontrolled diabetes mellitus, patients with bleeding disorders and patients on anticoagulant therapy, patients with lid abnormalities such as trichiasis, entropion, and ectropion, and patients with allergic conjunctivitis. Methods: after obtaining the informed consent, patients were randomly allotted into two groups for pterygium excision with superiotemporal clag, that was group 1, and excision with inferior clag, that was group 2. And 30 patients were allotted in each group. Pre-operative assessment included visual acuity using Snellen's chart, refraction, keratometry, IOP with non-contact tonometer, slit lamp examination, and lacrimal sac syringing was done. Surgeries were performed based on their allotted groups, and after the procedure, postoperative pain was recorded on visual analog scale for pain. Postoperatively, patients were assessed for symptoms including pain, watering, foreign body sensation, graft loss, displacement, and recurrence at day 1 postoperatively, and 1 week, 3 weeks, and 3 months following surgery. The procedure: under local anesthesia, that is peribulbar block, the pterygium was separated from the underlying structures and incised at the limbus, separating the body from the head of pterygium. The pterygium head is dissected from the cornea using reverse peeling method, and the pterygium body is separated from the underlying sclera and excised. And for the autograft, the desired size of the conjunctiva in either superiotemporal region, that is in group 1, or in the inferior region, that is in group 2, which was around 1 millimeter oversized and which included a part of the limbus, was marked. 0.5 ml of balanced salt solution was injected subconjunctivally, and the donor graft was excised. The excised tissue was placed on the bare sclera with epithelium facing up and with limbus to limbus approximation of graft and recipient bed. The edges were tucked under the surrounding conjunctiva, and the eye was padded and bandaged. Results: immediate postoperative pain in group 1, that is superiotemporal clag. Pain ranged from 2 to 6 on visual analog scale, and the median was found to be 4. In group 2, pain ranged from 2 to 5, and median was found to be 3, and which was found to be statistically significant. Therefore, postoperative pain was found to be significantly lesser in group 2, that is the inferior clag group. Postoperative symptoms and recurrence. Overall incidence of postoperative symptoms and complications like ocular pain, watering, and foreign body sensation was found to be higher in group 1, that is the superiotemporal group, in the follow-up period. There was 1 case of recurrence in group 1 and no cases in group 2. Discussion. Harvesting grafts from the inferior conjunctiva aims to preserve the superior conjunctiva for future filtration surgeries. In our study, we found that postoperative pain and symptoms were lower in group 2, that is in the inferior clag. Our findings were similar to those reported by Kui Chen et al., where they found postoperative foreign body sensation to be lower in the inferior conjunctival autograft group compared to superior conjunctival autograft group. They speculated that the upper eyelid had a greater range of motion than the lower eyelid, which might produce more ocular surface inflammation due to friction on the upper bulbar conjunctival defect area during blinking. Conclusion. We can conclude that pterygium excision with inferior limbal conjunctival autograft is highly efficient in terms of postoperative patient symptoms, safety, and efficacy, and it is preferred because the superior bulbar conjunctiva is intact for future surgical intervention. Thank you.
Which part of the inferior conjunctiva did you all use?
So the inferior, sir, there was not a lateral or medial, sir, just inferior.
The center, is it?
The
6
central
o'clock.
part. Yes,
Around 6 o'clock position.
Yes, sir.
Okay. You didn't go any sideways or?
No, sir.
Okay, yeah. Rashmi and Uma, anything?
No, sir.
No, so good
Okay.
study.
Yeah, okay. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you. We'll proceed to the next one. Wajiha?
Yes, sir.
Yeah.
Good afternoon. So, my paper presentation is on the topic of a clinical study of dry eye and its association with meibomian gland dysfunction in patients attending ophthalmology OPD in a tertiary care hospital. My chief author is Dr. Prajwali Reddy. So, dry eye workshop 2007 defined dry eye as a multifactorial disease of the tears and ocular surface that leads to symptoms of discomfort, visual disturbance, and tear film instability with potential damage to the ocular surface. Meibomian gland dysfunction is the most frequent cause of dry eye disease. The pathogenesis of both MGD and dry eye disease can be described in terms of a vicious circle. The underlying pathophysiology mechanism of dry eye disease and MGD interact, thus resulting in a double vicious circle. So purpose of my study is to study the frequency of occurrence of dry eye in hospital setting and to study an association between dry eye and meibomian gland dysfunction. So my study is a prospective observational study of 250 patients presenting with dry eye symptoms who are examined for meibomian gland secretion and opening, OSDI questionnaire, tear film breakup time test, rose Bengal staining of ocular surface, Schimmer's test, conjunctival impression cytology, and lipid profile. So inclusion criteria were all the patients above 18 years of age were presenting with the following symptoms like burning sensation, sandy or gritty feeling, blurring of vision, foreign body sensation, photophobia, and heavy lids. And signs included scanty tear film meniscus over the inferior lid margin, increased debris in the tear film, and increase in mucous threads in the inferior fornix. So exclusion criteria where patients with history of allergic conjunctivitis, acute ocular infections, ocular injuries, any ocular surgeries, connective tissue disorders, or use of any medication or use eye drops known to affect the ocular surface. So the data was statistically analyzed where we found that out of 250 patients, 179 patients had dry eye, which was around 72%. And out of 69 patients who were less than 30 years of age group, 17 patients had dry eye, and out of 59 patients between 31 to 40 years of age, 38 patients were found to have dry eye. And between the age group of 41 to 50, 77 patients out of 81 were having dry eye. And all the 46 patients who were more than 50 years of age had dry eye. And according to my study, 101 males had dry eye, and 78 females out of 118 females had dry eye disease. So when we studied the association of dry eye with clinical profile with the help of ocular surface disease index, it was found that 21 patients were having mild discomfort, and 94 patients were having moderate ocular discomfort, and 64 patients were having severe ocular discomfort. And when this lipid profile was done, it was found that out of 196 dyslipidemia patients, 125 patients had dry eye disease. So when the meibomian gland examination was done, it was found that 135 patients had grade 1 of dysfunction like cloudy or turbid discharge, and 96 patients had granular to turbid discharge with particulate matter, and 25 patients had inspissated or toothpaste-like expression. And when we saw the meibomian gland opening, around 135 patients were having 3 to 4 glands expressible, and around 100 patients were having 1 to 2 glands expressible, and 25 patients were having no glands expressible. When the data was analyzed, it was found that there is an association between meibomian gland dysfunction and dry eye with significant p-value. So out of 120 patients of grade 1 meibomian gland dysfunction, 54 were found to have dry eye disease, and out of 93 dysfunction patients, 89 patients were found to have dry eye disease, and out of 31 grade 3 meibomian gland dysfunction, 30 were found to have dry eye disease. And all the 6 patients who were having severe meibomian gland dysfunction had severe dry eye disease. So coming discussion, out of 250 patients, 179 patients, that is around 72% had dry eye disease. The prevalence of dry eye increased with increasing age and was significantly higher among people more than 40 years of age. It was high even in the age group of 31 to 40 years, as these were the occupationally active age group. OSDI questionnaire was used to measure dry eye symptoms, which helped in differentiating symptomatic from asymptomatic dry eye. Most patients came with moderate dry eye symptoms. Lipid profile helped to study clinical profile of dry eye patients, and it was seen that most patients who had dyslipidemia also had dry eyes. Meibomian gland examination is key in the diagnosis of the cause of dry eye and its appropriate treatment. So to conclude, dry eye and underdiagnosed ocular disease is a multifactorial heterogeneous disorder of the preocular tear film resulting in ocular surface disease. While considering the diagnosis of dry eye, meibomian gland examination is very important. Thus, all symptomatic patients should be evaluated with a suitable questionnaire along with standard tests for dry eye diagnosis and treatment, as the disease is chronic and needs long-term treatment. Thank you.
Thank you. Rashmi and Uma, anything?
How is your studies? I mean, what is new? Yeah, Vajiha, what is new about your study?
Ma'am, I found that 2 things. One is the dyslipidemia is strongly associated with the meibomian gland dysfunction, and there is an association between dry eye and meibomian gland dysfunction.
Uma ma'am, anything?
Nothing. I just wanted to do, will you start doing these tests in all these patients? Whenever you come across similar cases, will you start doing all these tests, what you say just now?
Ma'am, basic test like Schimmer's test, tear film breakup time, and ocular surface staining we can do first. Then if meibomian gland examination is abnormal, then we can do further investigate on meibomian gland.
Okay. Okay, fine.
Okay, thank you. So I think we finish with that. Thanks. Thank you, Uma, and thank you,
Thank
Rashmi.
you, sir.
Thank you.
Thank you, Rashmi. Bye.
Yeah, and you have that score sheet now with you?
Yeah, we'll be emailing it.
Yeah.
Yeah.
Just fill in. You can email.
Yes.
Thanks.
Yes,
Yeah,
sir.
thanks.
We will email, sir.
Thank
Yeah,
you. Thank you.
thanks. Yeah.